Hi, everyone. My name is Hannah Wise, and I am a bachelor's prepared nurse and a clinical nursing supervisor in the Trauma Neurosurgical Intensive Care Unit. And today I would like to talk to you guys about preparing yourselves for feeding tube placements at the bedside and how to perform a pre-placement patient assessment. So some learning objectives. After this session, I'm hoping that you guys will be able to create a plan for a successful bedside feeding tube placement, as well as identify key clinical conditions, as well as indicators that may impact feeding tube placement. So feeding tube insertions can be intimidating and time consuming, but I'm telling you that it doesn't have to be that way. For critical care staff in the intensive care setting who are responsible for placing feeding tubes at the bedside, I think we can all likely agree that any advice on how to increase your chances of a safe, efficient, and successful tube placement for our patients is that advice would be warmly welcomed. Over the last couple of years, I have found great success in my feeding tube insertions, and one thing that seems to continuously make a positive impact on this is ensuring I have anticipated all of the what ifs that could pop up during my placements, and which one of those what ifs would have otherwise created a barrier. Despite how common feeding tubes are used, they are not without potential complications. So in order to demonstrate this process for you all, I created a fictional patient scenario to just kind of guide us through each step. So I'd like to introduce you to today our patient, 72-year-old male, Mr. Fred Small. So Mr. Small is he was a trauma code 1 admitted overnight. He was riding his lawnmower and was struck by a pickup truck. He suffered significant injuries, including subarachnoid hemorrhages, some facial fractures, a basilar skull fracture, rib fractures with pulmonary contusions, a suspected tracheal injury, and an unstable burst fracture of L1. So keep those injuries in mind because we'll refer back to them throughout the presentation. Mr. Small is currently intubated and sedated in the ICU. So it's important to take a good look at your patient, not just physically, but what does the patient look like on paper? Usually where I start is I go to the computer, go to your electronic health record, log in, and this is where you can start gathering all of this data on your patient. This doesn't have to be a really lengthy process. Once you get into the groove of it, it really becomes quite quick. The first step in the plan is make sure you've got an order for your tube placement. You do, at least in our facility, it requires a licensed independent provider order for a tube placement. And then the very next step is, as a critical care nurse, we should always question, what are we doing for our patient and why? So at first thought, an indication for a tube for Mr. Small seems a little aggressive, quite frankly, but he hasn't even been in the ICU for 24 hours. Yet his respiratory status on the vent, is not getting any better. He has upcoming OR trips still pending for other injuries. So the likelihood of him being extubated, eating an oral diet are highly unlikely in the next 48 hours. And he's going to need a well-balanced, nutrient-dense diet to aid in his healing and recovery for this admission. So some initial questions to ask yourself: what is your patient's current clinical condition? So for Mr. Small, I would call him critical but stable. His blood pressure remains labile at times in relation to his sedation status. He does have intermittent times where he needs vasopressors to maintain those blood pressures in relation until we can get his volume status better. But at this point, ask yourself, is there any reason a tube insertion would otherwise be unreasonable for him right now? And there can't really think of one at this moment. So then moving on to the next step. For Mr. Small, it's obvious. Why is he in the ICU? Well, he's intubated, so he requires our care. Then think about, what was the patient's nutritional status prior to admission? Speaking with Mr. Small's wife, it sounds like he took a regular diet by mouth at home, so we're not up against any PO restrictions from that angle. Did the patient previously have a tube in the past? And if so, why? Be thinking, why was it intentionally removed? Did the patient remove it? Did we remove it during extubation, which isn't a big deal, but it's a key piece of information to note because you need to ensure that if the patient pulled it out themselves, then we need to either figure a different way to prevent it from coming out. So let's learn from our existing information. What do we already have readily available? 99% of the time in the ICU, you've got a recent history and physical, and you've got their past medical and surgical history at your fingertips. So ideally, you would have received this information during changeover report, but it's worth looking at if by chance you didn't. Mr. Small, for example, has a past medical history of hypertension, hyperlipidemia, coronary artery disease, significant ETOH abuse with known esophageal varices. So just by quickly reviewing that information, that can key you again in onto certain obstacles that you that may be present during a procedure. So next, I usually look at recent coag lab values. So each facility may have different triggers in terms of when you should call the provider to reconsider tube placement. For mine, we look at an INR greater than 2, a PTT greater than 50, or a platelet count less than 25,000. So honing in on the fact that your patient may be a little more friable because of their coag status, and then in turn paying attention to their hemodynamic stability. So are they requiring vasopressors already, and you're going to put this tube in and further, agitate them, and maybe they need to come off. So just keeping that in the back of your mind there. It's also important to understand your patient's level of consciousness. So is the patient sedated, and with what? Mr. Small is currently sedated and intubated on the vent, currently has a continuous IV infusion of fentanyl going at 50 mics an hour and a Precedex drip at 0.4 mics per kg per minute. So he does have bolus orders for fentanyl should we need them for tube placement. However, it is important to be aware that it was passed on report that his blood pressure does tend to trend down after medication boluses. So maybe thinking ahead, talk to the provider. Do we need maybe a benzo or something that is a little less harsh on the blood pressure? Should we need it if Mr. Small were to be agitated during tube placement? So again, paying attention to their respiratory status. Mr. Small is intubated or he is orally intubated with a 7.5 ET tube. It's also important to note that he has a finger pulse ox probe monitoring his oxygen saturation continuously, and it has a great waveform with 3 stars. It probably goes without saying, but the biggest risk one takes while performing a bedside tube placement is lung misplacement. So ensuring that your monitoring equipment is good. It's in good working order, giving accurate information, and this is going to save you time mid-placement, reapplying a pulse ox or having to worry that the information that you're receiving is inaccurate. So when inserting a feeding tube, it's really important that you and your physician are on the same page in terms of what's our goal? Where are we trying to go with this tube exactly? So you want to determine that before you even get started. Some of your patients may benefit more from a tube that terminates in the small intestine versus in the stomach. Do they have a long-standing history of gastroparesis? Are they going to have this delayed emptying? Are you taking care of an acute pancreatitis patient where they would benefit from the bypass of the duodenum and get it towards the ligament of Treitz or past that? So all things to be thinking about and having that conversation with your physician. So taking into consideration next anatomical barriers. So injuries to the head, face, and neck region do pose an additional risk of injury during insertion. So if you recall our patient, Mr. Small, he has a basilar skull fracture, which means there is a threat of tube placement that can travel north up into the brain. So while it seems kind of far-fetched, there are documented cases of this occurring, which just makes it one too many. So anytime you have a patient with a known basilar skull fracture, the nasal passage is off limits. So for him, we'll have to go the oral approach. Another anatomical barrier that we could come across with him is that he does have a history of esophageal varices. So while it may not necessarily prevent our tube from getting down, we've really got to be cognizant that we aren't poking and prodding too much in there because he could be a little more friable than others. His wife did report that he hasn't had any recent issues with them, but it is good information to know. Additionally, other anatomical barriers to keep in mind are hiatal hernias that can make it difficult to get into the stomach right at that GE junction, or somebody who's had a Roux-en-Y. That's always nice to know ahead of time because you're truly not, if you're going for a post-pyloric placement, you actually don't have a pylorus anymore. So just knowing that what to anticipate on your tracing. So moving on to mechanical barriers, we've kind of touched on the anatomical ones. What we know, unfortunately, about mechanical barriers is that we have put them in place, but it's what it takes to care for our patients. So endotracheal tubes can pose an obvious barrier for oral insertions. I mentioned above the esophageal temperature probes and orogastric, nasogastric tubes, because most of the time, those are devices that do have good intention, but you can talk with your provider and see, can we pull those out if it creates a barrier for tube insertion? Is the patient a candidate to leave that Salem sump out now because they've been decompressed and don't have high volumes of residuals anymore? So just having those conversations ahead of time. Other mechanical barriers can be a cervical collar. It helps to facilitate esophageal placement by tilting your patient's head forward, but if they've got a C collar on, it's inappropriate to do so. So keeping that in mind, and then can you position the patient optimally, not just for head placement, but so for Mr. Small, he's got an L1 burst fracture. So you've got to be really cognizant for somebody who is on strict spinal precautions to not be manipulating their head of bed up and down during insertion. So my last step for feeding tube pre-placement plan is what I like to call the grocery list. So this is a mental checklist that I use every single time, and I gather the same supplies every time. I always try and set myself up for success, because there's nothing worse than getting into your room and you've got it all in place, but you've then forgot the silk tape to secure it. So try and get into the habit of that. Get your feeding tube, your syringe, your stethoscope, securement devices. Did the patient have a tube previously and pulled it out? Maybe we should consider a nasal bridle this time. Have some securement tape. There are other devices out there. Make sure you've got your feeding tube insertion machine at the bedside, lots of lubricant, and then any kind of PRN medication. So we discussed before, Mr. Small was on continuous fentanyl and Precedex, but would it have been any use to speak with the physician about maybe getting like a PRN Versed should we need it if he becomes agitated? So in conclusion, we have walked through step by step on how to navigate our pre-placement plan and what information needs to be gathered prior to insertion. So it's imperative to confirm that you've got an LIP order, the appropriate indication, factor in your patient's current clinical state, quick review of the body systems, consider patient's nutritional need and pre-admission nutritional status, ensure any safety equipment, your pulse ox, suction, all of that's available and in working order prior to going in or getting started, and then identify any anatomical or mechanical barriers you might endure, gather any necessary supplies for the procedure, and then most importantly, and I think I'm guilty myself, explain the procedure to the patient and answer any questions prior to starting. I find a lot of times I go in to put tubes into my patients, and you need to slow down a bit and explain what they can anticipate and what you're going to do to try and keep them comfortable. So I thank you all for your time today and encourage you moving forward to feel empowered in your bedside pre-procedure assessment now that you've been armed with some tools to do so. So I hope you have the same increase in success in tube placements by taking the same approach. Thanks for your time.